Well, hi, everybody. My name is Garrett Schmidt, and I'm the CEO and managing editor for VBC Exhibit Hall. I'd like to welcome you all to today's live webinar hosted by MRO Health, and it is called Breaking Down Barriers Best Practices to Align with CMS Proposed Quality Initiatives for 2025 and beyond. And we've got a great presentation and a great speaker who I'll introduce in a moment for us today. A few items of note before we get started. This is a traditional webinar format, so everyone has joined today in listen-only mode, so you don't need to worry about muting your microphone or turning off your camera or anything like that. No worries there. However, we do want to hear from you, and we're going to have a time for some Q&A towards the end of the presentation. So if you have a question at any time during the presentation today, go ahead and drop your question into, you have a control module as an attendee, and there's an area for questions specifically. So go ahead and put your question there, and if we have enough time, we're going to get to as many as we can. If for some reason we aren't able to get to yours, if we run out of time, don't worry. Someone will make sure to get back to you via email afterwards. So make sure to just drop your question in there, even if we're wrapping up at the last second. Finally, the session today is being recorded, and so what's going to happen is when we're done, I would say maybe about an hour after we wrap up, you'll receive a link to where you'll have the recording, and you can access the recording and also download the slides, and there'll be some other information there for you as well. So without further ado, I want to introduce our speaker today, Mr. James Pelletier, and he is the National Director of Provider Quality at MRO, and he will be our guide. So welcome, James.
Thank you very much, Garrett. Um, on behalf of MRO, I want to thank obviously the VBC Exhibit Hall for allowing us the opportunity to have this discussion with you guys, and thank each of you that are attending and took the time to register and took the time out of your day today to listen to this discussion. I have a lot to cover and not that much time, but I hope that this is as productive as possible. Just to reinforce what Garrett just mentioned, by far my favorite part of doing these things is the Q&A. So definitely encourage as many questions as possible. We'll try to leave as much time at the end as possible to allow for those types of discussions and interactions. That way, of course, we know that you're getting something out of this, whether it is new information that is being presented or again, kind of details that maybe I don't have enough time to get into today. So please, again, keep those coming. A little bit about myself. My name is James Pelletier. I have been in healthcare technology since the early 2000s. I've worked for some of the major EMR companies, and since about 2009, been really focused on the population health space. So value-based care, working with ACOs on things like data aggregation, care coordination, analytics, patient engagement, all very, very near and dear to my heart. I appreciate what you guys do, both care providers and non-care providers, because I think we are all working towards a greater mission of not only lowering costs, but improving patient outcomes. And specifically, that's kind of what drives me in my healthcare career. And I've been with MRO for the last 2 years and have had the opportunity to really get deep into the new reporting requirements that are for MSSP organizations. And that's really what we're focused on today. Many of the new changes that are going into effect in 2025 are things that we've known about for a while, but also there have been some new proposals that have just come up that may change the way we are looking at 2025 and how we decide to accomplish our goals with respect to maximizing performance and again improving patient outcomes. So now that I've introduced myself, we do have a couple of poll questions just to kind of kick us off and get a little bit of interaction between you and I can get maybe a better understanding. So with that, I'm going to ask Garrett to jump in and provide us with that poll question.
All right, so this is pulled up on your screen. And by the way, we are going to have a couple of these polling questions, and these are all anonymous. So and we're going to show the results so you can kind of see where you stack among your colleagues. So this first question is, how confident are you that your organization is ready to transition to the new Medicare reporting guidelines for ECQM and Medicare CQM? This is a 1 through 5. Just choose the best that applies. From very nervous to not so nervous, very confident, or somewhere in the middle. And we've still got a lot of results coming in here, so we'll keep it open for a few more seconds as people continue to answer, and then we will show you all the results. Okay, I think most people have voted. Ooh, there's a few coming in here still. I think most people have voted here, so I'm going to shut it down in another 5 seconds. 5, 4, 3, a couple more, a couple long 5 seconds. And all right, we're going to go ahead and shut it down, and then I will share the results for you to see. Here we go. Okay, James, I know you can't see this on your end, so I'll read out the results to you. For very nervous, we have 15%. For number 2, we have 22%, so a little less nervous, but still pretty nervous. 3, right in the middle, it's about 37%, right in the middle. And
Mm-hmm.
and for 4, for feeling a little bit of confident, we have 20%, and then very confident, we have 7%. So definitely in the
Oh,
minority there.
that's interesting. Interesting. So we're definitely weighted towards the middle to nervous section, um, which is obviously very understandable. This is a big change, and a lot is riding on organizations' ability to be able to accurately report the quality of care that they're providing. I think that's probably where a lot of those nerves are coming from. Is I know that my doctors are great at providing great quality care, but how do I translate that to what Medicare is now telling them that I need to send them in order to get the credit that I deserve? And of course, the financial incentives that are tied into your quality. Um, there's a lot of risks obviously involved with making these decisions and how we move forward. So I can appreciate that, and I think the poll question number 2 is going to come up now, kind of tying into that. So go ahead, Garrett.
Yeah. Okay, second question here. It is up on your screen. And this is, what is your biggest concern or risk associated with the upcoming changes? And this is a choose one that most applies. Is it cost, quality performance and shared savings, provider buy-in, EHR compliance, or data accuracy? And some of you may be saying, well, all of these things. But just if you had to pick one, what is the thing that is your biggest concern or risk
Mhm.
associated with the upcoming changes? So we've got the results are pouring in here, and we'll give folks a little bit of time to answer. And looks like most people have answered by this point, and so give it another 10 seconds or so, and then I'll shut it down. Okay, I'm going to close it down in 5, 4, 3, 2, and 1, and I'm going to share the results. Okay, so all right, here's the results. So cost is 13% of you said that the cost is the biggest concern, risk. Quality, performance, and shared savings, 21% of you said that that was the biggest concern. Provider buy-in, we have 11%, which is actually, I think, the lowest of them, just next to cost. And then EHR compliance, that's a bigger one. That's at 23% of you said that. And then the biggest one is data accuracy at 32%. That's the biggest concern.
Cool. Again, not a total shocker to me, and I think that is extremely relevant to the reality of the fact that again, for the most part, services are being provided, but oftentimes physicians document differently, and information lives in many, many different places. It used to be, or I guess I should say it still is with the web interface that's still existing. You had the ability to be able to work around not having all the data all in one place with a lot of manual effort. But the volume of patients that we now are going to be reporting on, I think, makes that almost untenable, if not much less realistic, to be able to do the types of chart reviews that we were able to do with a sampling of the patients that we're seeing throughout the year. Um, so yeah, data accuracy, is my EHR capable of producing a QRDA1 file? Are they mapping the data correctly? If the data is not mapped correctly, how will I, you know, request that those changes be made? So, we're relying on a lot of different organizations and vendors and people to ensure that we reach that end goal of maximum shared savings and performance. But again, people are people; they're human. So provider change is going to be something that we should all be focused on, making sure they understand what those changes are and what they need to do. Understanding again, are they on a certified EHR, which would be one of the requirements for ECQM? And if so, where is that field that their EHR is expecting that data to be coded? So I could go on and on just on that one poll question alone, but I'm sure I'll allude more to that as we go forward. So again, I have a lot to cover. I do want to give you a quick introduction to who is MRO for those of you that are unfamiliar. Um, MRO is a company that is focused on clinical data exchange. And again, I've been with MRO for 2 years, very much focused on helping groups or ACOs transition from web interface to the new reporting requirements. Um, as a company, we are involved in lots of different areas within healthcare, from release of information, where we are connected to all the payers in the U.S., and working with health systems to ensure that all of the requests that they get from payers and all the other entities that are requesting medical records from them are getting to the right people in a timely and efficient manner. So we've achieved best in class status for 9 years in a row. And MRO is really synonymous with um, that work that we're doing for organizations and health systems. We are also known for our registry capabilities. MRO purchased a company that, and some people still know the FigMD name, so I like to mention it because if you know FigMD, you know a part of the technology and services that we're utilizing for ECQM and CQM submissions. That registry experience has allowed us to connect to data or EHR systems, and aggregate and normalize that data and utilize it for a variety of different functions. It has allowed us to understand how physicians document and ultimately how best to help ensure that they're getting the credit they deserve for the quality of care that they're providing. So these are all the different areas that we're involved in. Supplemental data files is another one that I'll mention that is sometimes top of mind for ACOs like yourself. Um, so just to kind of give you guys an idea of that background. We've achieved a lot of certifications. The most relevant ones, I think, again, are being best in class, high trust certified, um, the NCQA data aggregator validation, I think, is important as well. One thing that you'll notice about us is that we are much more of a data platform than just an aggregator of flat files. We don't just consume QRDA1 files, although sometimes that's necessary. Direct integration with EHRs allows us to do more than just calculate measures and submit on your behalf, but really help you understand why gaps exist, not just that they do exist. So there's again a lot of different use cases and capabilities within the technology and framework that we've built, from again different quality measures to looking at risk and again just connecting to all the different systems and making sense of that data. So again, I know I'm preaching to the choir with a lot of this stuff, but data aggregation in healthcare is hard. It's a heavy lift, and that's one of the things that I think helps us stand out in this particular space. We're not coming just from web interface reporting capabilities and trying to transition with you. We've been doing this for a long time on behalf of different medical societies and registries that we are operating. And one of the things that I guess you should know that is mentioned there at the bottom of the screen is that while this is all new to most of us, we are one of the most experienced companies in this area, as you will find. We have been submitting ECQM and CQM measures since the very first performance year in 2021, and have continued to submit every year since then. And it's typically a combination of ECQM and CQMs. So ultimately, all of our services and technology are designed to help maximize performance. So we try to provide all the different ways that you can report so that you can choose the one that ultimately is going to net you the best outcome. And I won't spend that much time on this slide. Just want to let you know that at mrocorp.com, you'll find lots of other resources that you might find helpful, all pertaining to some of these different changes that we're talking about right now. Some of them were authored by me, so I apologize for that. But again, great resources for you to maybe take advantage of and help to continue to educate yourself on how to best prepare. So a couple of weeks ago, I guess it was maybe in July, CMS released their new proposal for changes to MSSP reporting for 2025. We are still in the comment period, so some of you may know that, but you still have an opportunity to respond by September 9th of this year, and provide your own comments and thoughts on the changes that are being proposed. What we know from Medicare is that change is a constant, and that they often do present new changes, even with just 3 or 4 months before these changes would take effect. So some of them are maybe more likely than others to be adopted into rule, but I would say as a whole, from my perspective, it seems like most of them will be going forward. And it's not all bad news. There are some things that they're doing that will further incent you to do things like report ECQM measures rather than CQM measures, and things like data completeness thresholds of 75% are being extended into 2025 as well. So no doubt that some of the changes are making things more difficult and adding some complexity, but it is kind of a give and take. And I think the signs that we've been seeing throughout, at least over the last year, if not longer, are that we're going to continue to march towards an all-payer, all-patient requirement, and the ECQM measures are not just going to be limited to the 3 that we're already used to, for those of you that have been submitting, but we'll be expanding more than likely to 5 for next year and the year after. To 8 for next year and the year after, and then up to 9 in 2026 and 11 in 2027. So again, they are trying to help ease us, and I think this grace period of it being optional since 2021, some of you have taken advantage of that and some of you have not. But starting in January, this is going to be the new way of reporting on the quality of care that you provide. So looking at some of the things that are on the screen, I'm certainly not going to go through all of these, but they all are impacting you in different ways. We're going to dive into some of these a little bit more, but things like allowing you to adjust for rural healthcare and patients that are underserved. Those types of adjustments will help to improve your overall ability to collect some of those shared savings. And the addition of things like colorectal cancer screening and breast cancer screening. Not the end of the world, but just more data points that are going to need to be tracked and verified in order to ensure that you're getting, again, the credit you deserve. So let's move on from this slide. I think I've said enough about it. These are the 4 things that I think I wanted to focus on the most when it comes to the changes, especially as it relates to some of the things that we're doing on behalf of our customers and the ACOs that we work with. So the first thing I wanted to hit on is the additional quality measures and the elimination of MIPS CQMs. So the elimination of MIPS CQMs is not necessarily as noteworthy as it would have been had they not introduced Medicare CQMs as an option. So I'll talk a little bit about the differences between an ECQM measure and a Medicare CQM, and sort of how that might be important to how you decide to proceed in terms of measurement and calculations and your ultimate submission. So with the elimination of Medicare CQMs, they are trying to make things a little bit easier and simplify things so that you don't have the three different options. And trying to, again, kind of eliminate some of the complexities associated with that work. The main difference, I think, between ECQMs and CQMs is that ECQMs rely on unstructured data. I'm sorry, unstructured data. Sorry, I misspoke there. So with ECQMs, there are certain fields within your EHRs that need to be coded appropriately in order for that to get mapped to the quality reporting that is consumed by companies like MRO. And that work is, or that structured data, I guess I should say, is very rigid in terms of what you need to do to get credit. With respect to CQMs, they're the exact same measures, but the way that we calculate it is different in that Medicare does allow for chart reviews in order to calculate your quality measures as it relates to, depression screening, for example. So what that means is that there may be data in your notes, in the physician's notes, that indicate that a depression screening took place, but they didn't code it correctly. And so that level of chart review, I think, becomes very, very difficult because, again, we're not talking about 250 sample patients per measure, but all of your Medicare patients that are seen, you would want to do that kind of gap analysis. But that's a very manual process for most organizations that are relying on the flat files that EHRs are producing, which are the QRDA1 files. And I apologize for some of you. I know most of you know all of these acronyms, but there are so many in healthcare. So if you don't know some of them, I do apologize. But I want to make sure that we're getting to the level of detail that is important for most of the people that are on this call. So I assume most of you have been in value-based care for a long time and know some of these even new acronyms like QRDA1 files. So that's what needs that an EHR would push out to vendors like us in order to get all the data that they need to do these calculations. The other part of this note is the additional quality measures. So currently, or in this performance year and in past performance years, we were looking at diabetes control, depression screening, and all of a sudden I'm drawing a blank, depression screening, and high blood pressure, hypertension. And so what they're proposing for next year is to add colorectal cancer screening as well as breast cancer screening. And one of the things that they're also indicating here is that the addition of these two measures, as well as the addition of future measures, are going to more closely align with the adult universal foundation measure set. So they're trying to, again, make it easier for these measures to not just be unique to your MSSP reporting, but also to your Medicaid contracts and some of the other quality measures that you're already reporting for other value-based care contracts. Next on our list is the additional incentives for ECQM. And I think this is, certainly good news for those that are capable of submitting ECQMs. So of course, with any change, there oftentimes is a carrot or a stick. You're either going to get penalized for noncompliance, or they're going to incent you to comply. Again, everything we've seen since the beginning of this program is that they are pushing towards that all patient, all payer reporting requirement. So give me data for every patient that came into your office that has diabetes, rather than just the ones that are part of your Medicare population and the ones that you're serving under the MSSP agreement. So the additional measures, again, are not necessarily something that is uncommon, and for most primary care physicians especially, they're very much commonplace to do these things. So The gap here is that now there's, instead of three measures, there's five, and five other opportunities for human error where, again, you may be searching through notes, or you may just be educating the physician on where they need to document those screenings in order to get the credit they deserve. From what I know from physicians, they don't want to be distracted with all these other administrative requirements, but they do want to get credit, and they are competitive. And can, you don't want to have a physician that is an outlier where they're providing just as high a quality of care as everybody else, but they just um, are not documenting correctly or whatnot. So those are the challenges again with ECQMs, where it's just a very rigid requirement in terms of submission. The other thing I will mention about ECQMs is that all EHRs within your ACO must be certified. So if you have some physicians that are on non-certified EHRs and or on paper, ECQM is probably not going to be an option for you, at least for 2025, or at least until Medicare CQMs potentially goes away, which they have also hinted at with a new proposal. As I'm sure some of you have already read, more than likely Medicare CQM will go away. Don't know if that's going to be after next year or the year after, but certainly it's going to be in place for performance year 2025. The other thing they're doing with the new proposal is they are looking at a complex organizational adjustment. So this is to address some of the unique challenges faced by virtual groups, and where CMS is proposing complex organizational adjustments starting next year. What it does is it aims to fairly assess performance based on by awarding achievement points for each ECQM meeting specific criteria. So it's helping to support organizations based on the complexity of the patients that they're providing care to, without compromising quality assessment standards and things like that. So again, those rural communities that you're serving, hopefully you will get a bump up in terms of the achievement points to earn the shared savings that you deserve. And then the scoring of Medicare CQMs. There are no benchmarks for Medicare CQMs yet. So we are looking at a flat historical benchmark for Medicare CQMs going forward. Again, I don't know how much that's going to impact us yet, because again, we just don't have data on how an average or AC organization is going to score for Medicare CQMs. But as they get more and more historical data, we will have a more accurate benchmark, and obviously something that we are going to be striving for as we look to calculate these throughout the year as well. So very important stuff. I do want to move on and get into, well, I guess a couple of other things of note. Again, I don't like to dive into and read slides verbatim, but hopefully this information is valuable to you in terms of summarizing some of the things that are part of the proposal. A gradual phase out of MIPS, and the kind of the evolution of MVP organizations. We've had 6 new MVPs for performance year 2025, and I think Medicare is wanting that to continue to grow and phase out the MIPS program. Again, I measured additional quality measures that are aligning with the Adult Universal Foundation quality measures. Data completeness. This is, again, something that I think Medicare has done for organizations to not make it 100% requirement that you're reporting on every patient that you see. That 75% completeness threshold is being extended out to 2027 and 2028. So that was, again, good news for organizations. And then simplifying scoring for improvement activities, and removing of reweighting for clinical social workers. So that was something I think CMS heard from a lot of organizations, and probably even NACOS on your behalf, where you're getting penalized for clinical social worker services that really wasn't deserved. So that adjustment, I think, is being made as well, and obviously is beneficial to you. So the path forward, and I think we have one more poll question that we want to get into before we start talking about, well, how do we solve for these new changes, and how does it affect me? So with that, I'm going to ask Eric to ask the poll question.
Okay, so I'm pulling up the final poll question here. And this one is, have you chosen a vendor or qualified registry for your 2025 submission? And this is, again, a choose one that best applies. Yes, a vendor that only supports flat file uploads is the first. Yes, a vendor that supports direct EHR connections. And the oops, I wonder if we're missing a little text on that one. Uh, and then the third is James. Do you have that full question, the polling question for the second one that you could?
Sure I do. Hold on.
Sorry, I must have gotten stuck with a word count issue there. Let's see if I can pull it up.
Yeah, I'm sorry.
Oh, you're good. We are working live here, folks. Okay, I got it. Polling question two is uh,
Have you chosen a vendor or a qualified registry for your 2025 submission? Option A should be yes, a vendor that only supports the flat file uploads like a QRDA1 for submission.
correct.
Option 2 should be yes, a vendor that supports direct EHR connections and the ability to utilize unstructured data.
There we go.
Third option is yes, we have one EHR in our ACO and we'll be submitting through them. And then the fourth one is not yet.
Okay, yeah, thanks for that. Yeah, we were just missing a couple words on the end of question two and three. So we'll give you guys another few seconds to complete that. I think most of you have voted, but and again, that question two is that again, it's cut off there is yes, a vendor that supports direct EHR connections and the ability to utilize unstructured data. That's
Right.
the end of that one. And then the third is that yes, we have one EHR in our ACO, and we'll be submitting through them. So,
Mhm.
okay, I think most of you have voted, so I'm going to go ahead and close it out here in another 5 seconds. 4, 3, 2, and 1, and then I'm going to share the results. Okay, so for the first answer is yes, a vendor that only supports flat file uploads. That is 6%, so that's the least of the responses. The second is yes, a vendor that supports direct EHR connections, and that is 22%.
Okay.
And the ability to utilize unstructured data. The third is yes, we have one EHR in our ACO and be submitting through them. That's 22%. So that's actually tied those answers. And then the third is, or the fourth rather, is not yet, and that's 50% of you. So don't feel bad. You guys are not in bad company there. A lot of folks still undecided.
Yeah. Very telling. That is interesting. So, um, the interesting thing about that poll is that the last information I could find regarding the number of MSSP ACOs that had one EHR was from 2023, where NACOS did a poll, and it was 17% of all ACO or MSSPs had one EHR.
Oh wow.
This is kind of informal, but it's not that far away with 22% that had one EHR. Um, so that's definitely one thing that I noted based on that. The second is that the not yets, and I'm curious about that because while this requirement kind of extends all the way back, into 2026, where in February or March of 2026 you will be reporting on next year, 2025. Um, Most organizations that I know do want to have a system in place by January so that they can properly ramp up and not just have to dump all the data they have throughout 2025 at the end of the year in order to do this reporting. Um, so maybe some of you are still evaluating and you're intending to make a decision soon. I've certainly been as busy as I've ever been in the 2 years that I've been at MRO, so I definitely can feel that as well. But one of the things that I would encourage is to have these connections completed and for having the ability to measure how you're performing as early on in that performance year as possible, so that you can make the changes appropriate to ensure that by December or by January, February of the following year, as many of those gaps have been filled, and as much provider change management needed to take place, and education, et cetera, happened, and you're getting, again, maximum shared savings and high quality scores for the care you provide. So that's very, very telling. I'm glad we asked that. I wasn't sure how weighted it would be towards. Um, the other thing to note is that MRO is kind of that second option. We certainly can consume files, but we prefer direct EHR connectivity for some of the reasons that I mentioned earlier. Having the ability to look beyond the data that's provided in a flat file and look at unstructured data and other HR where one particular doctor tends to always document in this field instead of this field. Working with a vendor like us that has that direct connection is going to allow us to just simply remap where we're pulling the data from, so that you don't have to necessarily change the way the physician documents, but still get the credit. So let's move on from that, talk about some of these best practices. And again, a little bit of a sales pitch here where we talk about MRO's capabilities and why some of the things I'm talking about are so important. There are organizations, again, that are just wanting to check the box. They want to, have a vendor that is going to allow us to do these calculations and submit. But more and more, I think it's going to be important that you choose the right vendor that has sophistication and capabilities beyond just aggregating flat files. Our experience in that data platform is the kind of the foundation of everything that we do. We're not reinventing the wheel in terms of aggregating clinical data and measuring quality, et cetera. But the technology and services working in conjunction with each other allows us, I think, to have better performance than maybe some of the other options out there. If you have a vendor that is only going to communicate with you at the ACO level, and then put that burden of communicating and getting access to all this data on the ACO to communicate with practices, et cetera, that's one way to go about it. It's not necessarily our preferred way. By eliminating the middleman and easing the burden on the ACO to not have to do all that manual effort and running around and getting access, we can kind of speed things up and simplify things so that everyone is kind of running like a more well-oiled machines. We have calls at the practice level and at the ACO level, so everyone has transparency. They all have their view of how they're performing. So at the practice level, those administrators can see, again, what their quality performance is, what each one of their physicians' quality performance is, and again, work with us in a collaborative way to ensure that we can make improvements throughout the year and have the results speak for themselves. So provider change management, again, a slide just to kind of talk about it, but I'm sure this is top of mind. I think we had 11% this is one of their top concerns. I'm sure it's a concern for all. We have, one of the things that we're providing is documentation and best practice guides to help at the practice level prepare for these changes. Working with each of the individual EHR vendors, as I mentioned earlier, to know what are their requirements, and then again, helping the clinicians and the caregivers understand what is needed in order for them to comply. Hopefully that goes away over time, but again, as we know, colorectal cancer screening is probably getting added, and there will be more in the future. So this will evolve, but what they're going to see is that there's a lot less scrambling in February and March, a lot less manual effort in the ACO to run around and kind of connect all the different data systems, and more of it's happening kind of throughout the year. So being more proactive in terms of the documentation that's required. So whatever training and education you can provide, the better. The more dashboard updates and just having that understanding of how am I performing and why, I think will be important. And regular dashboards updates go hand in hand. So transparency, accountability, how can I improve? What am I doing wrong? If I am doing something wrong, maybe there's low hanging fruit where we can identify patients or a different field as I mentioned earlier. Let's just remap this so that this physician is that so that we're pulling the data from the right place where this physician likes to document. All very, very important. And I think this gets into that as well. It's important to know that a measure has failed. It's even better to know why it's failed. So, the great thing about utilizing data is that there are insights within it, and providing real-time insights and alerts and relevant information that can be utilized to make improvements, I think is an important part of this as well. So there may be just a matter of making sure that you're getting credit, and there may be other opportunities where you can do better and again provide better services and better outcomes to patients. So leveraging that technology and identifying gaps and where you can make improvements, I think is huge. And of course, maximizing incentives. That's why these ACOs exist. If they weren't profitable, if there wasn't shared savings, if there wasn't some risk involved and reward, this probably wouldn't be very successful. But in value-based care, I think the great part about it is that we are focusing on the patients and being more proactive with their care, ensuring that we treat them like individuals and not just wait for them to come into the office in order to be seen, but follow them and ensure that they're getting their medications and that we can eliminate perhaps emergency room visits or potential traumatic events from occurring by being more proactive and screening them for breast cancer um, and diabetes, et cetera, et cetera. So all good things, and I think all part of the mission of any value-based care organization as hopefully we're all continuing to grow and continuing to add new contracts and new patients that fall under these types of agreements. And one thing I will mention as well, I think historically we've seen this, commercial payers tend to follow Medicare's lead. So while we're doing all this heavy lifting currently for just this MSSP contract that we have under the ACO, I'm sure that we'll see other vendors or other payers start to adopt some of these new measures and some of the new requirements moving forward as well. So this work hopefully will be utilized to get value out of it in other ways in the future. Um, so every ACO is different. I think that's the point I wanted to make here when it comes to choosing the right partner. Um, some EHRs are less complex than others. Many ACOs, I'm sure, that are on this call right now have lots of independent practices, 1 and 2 doc practices that may not have the resources or IT staff that others do. So keep all of those things in mind, especially when you are considering, when you're making all the decisions associated with how do I connect to data and how am I going to implement provider change management and how do I choose between Medicare CQMs and ECQMs. Your organizational needs and priorities, I think, will help drive that, but also consider the value of sort of just checking the box on one hand versus a company that more like MRO that's kind of end-to-end technology and services and commitment to getting the results that you're looking for. And right at 2:44, according to my clock, I think we are ready for Q&A. So hopefully this time that I've been talking exclusively along with you a little bit, Garrett. We've gotten lots of questions already pouring in, and
Oh,
if
yeah.
not anything top of mind for you guys, please type them in now.
Yeah, for sure. And we do have a lot of questions. And if you do have a question out there and you haven't submitted it yet, go ahead and do so. Using your control module, there's a place for questions specifically. We're going to get to as many as we can. If we run out of time, don't worry. someone will get back to you via email to answer your question. So just go ahead and drop it in there, as many as you would like, even if you have more than one question. All right, with in no particular order, I'm going to go ahead and ask this one first because it seems like a good natural starting place. Um, what are the differences between ECQMs and Medicare CQMs?
So I sort of alluded to it earlier. One of the differences, I guess the point I made earlier about um, the difference between Medicare CQMs and ECQMs is how we calculate. So we have the same three measures: hypertension, diabetes, and depression screening, and they're measuring the same thing, but how we calculate them is different. So electronic clinical quality measures, ECQMs, comes from structured data, a field that needs to be coded appropriately within the EHR. That's where that data has to be in order for us um, to calculate and give them credit for that particular quality measure. With CQMs, it can be anywhere within the EHR, including in the unstructured notes and data and things like that. Um, and so again, with CQM measurement, it allows for you to go into the chart and see, well, a depression screening was done, so we're going to count that patient as a a thumbs up, um, even though it hasn't been documented correctly. So there's a difference between pulling data from unstructured data fields versus unstructured with the two different types of quality measures, and then also the population. So, as you might expect, Medicare CQMs is just limited to your Medicare population. That's the population you're reporting those measures on. ECQM is patients, all payers. So, all your commercial payers, and all the specialties associated with those as well.
Great. Next question here, and there's a couple, and forgive me in advance if some of these are somewhat repetitive, and if they are, just say I think we've already hit on that because I am not the
Okay.
expert here. Next question is, we have some non-certified EHRs in our ACO, and as long as we report CQMs, then we should be okay in reporting, right? At least until CMS mandates reporting on ECQMs.
You nailed it. You nailed it. So, as long as Medicare CQMs continues to be an option, you don't have to have 100% compliance in terms of the certification of your EHRs. But you do have to have that certification if you plan on doing ECQM submissions. So for some of the basic track ACOs that I'm sure are on here, you have that Medicare CQM to fall back on. So in that case, we would only measure CQMs for you, and obviously we'd be limited to that submission. But that will continue to be an option as we understand it up until Medicare CQMs go away. So, and it sounded like they understood that as well.
Good deal.
Yeah.
Next question here is my ACO has a lot of independent and small practices with little support staff or IT. What is the best way to prepare them for the upcoming changes?
Well, again, I think we know change is always difficult, and it's hard. The challenge for one and two doctor practices is it's more difficult than it is for ones that have more resources and more expertise because those organizations are already stretched thin.
Mhm.
They're running their practice. They have more than just value-based care patients that are coming in the door, sick patients, etc. And so the issue I think is that you can't do this on your own as an ACO. You have to have some buy-in from practices and some level of engagement. The great thing about our services is that we've kind of seen all types of groups from one doctor practices up to the more sophisticated ones. And I'm not saying all one and two doctor practices aren't sophisticated, but we can do a little bit more hand holding than what might be necessary for other organizations
Mhm.
to based on our experience. So we are not a company that is going to say, okay, well, you have Athena. We've never worked with them before, but can you teach us about your Athena and tell us who we should contact? We go into those having worked with Athena many, many times, having our own contacts at Athena, and alleviating as much as possible of the burden on the administrator or whoever we're connecting with, and saying, just give us a contact number, tell us what your practice name is, give us the permission that we need, and we'll take it from here. So, um, that hands-on approach at the practice level, I think, is kind of the white glove service that we provide that you otherwise as an ACO, and I'm sure that ACOs are already doing this on some level, um, trying to get buy-in and things on different initiatives from practices. So they understand this more than anybody, but we try to be as flexible as possible to provide more resources for the groups that need it.
Makes sense.
Good question.
All right, next question here is, and this is, let me know if this makes sense to you. It probably makes sense more to you than to me. If you are pulling and remapping to discrete fields or codes, are you considering this CQM or ECQM?
That can also be for ECQM. So I think I understand the question in that um, most of the EHRs have a certain field that they're expecting that data to be documented in. And the reason why they're going to kind of make it seem mandatory is because a lot of vendors out there are just relying on QRDA1 files. So
Mm-hmm.
these QRDA1 files are mapping to specific fields, and there's no flexibility for the EHR company to change those fields so that the QRDA1 is populating from a different field rather than the one that they already pre-mapped it to. That's why working with a vendor like us that has that pull capability, CMS is not telling us it has to be in a particular field. They're just telling us it has to be within a certified EHR, or it has to be, has to derive from the EHR. Um, so those requirements in terms of which field we're pulling it from, a lot of times that confusion is just based on if you're doing just a QRDA1 pull. In that case, again, as a vendor who's consuming those QRDA1 files, we just get the data that we get without the ability to be able to look upstream and say, well, let's remap this for this particular doc or for this particular practice, because maybe that one practice uses Athena different than the other practice that of the same specialty. So it doesn't only have to apply to one doc, but I guess to summarize my answer to that question, it doesn't necessarily need to be in a particular field if we have a pull connection or a read-only access to the database of that source system.
Got it. All right, next question. Um, can you let me know how do you handle data quality, especially coverage and availability of codes and data in the underlying EMRs?
So a lot of that heavy lifting happens during an implementation, and a lot of it is based on the experience that we have having worked with that vendor. We generally have an understanding of where data lives for particular EHRs, but we also know that, again, there's changes and everyone uses them differently. And so we make all the connections that we need to initially, and then we kind of run the dashboard and say, does this look like we would expect it to look, and if not, why? So that type of, then that's why I think the runway of having these dashboards in place starting in January and understanding how you're performing throughout the year, you can identify, outliers or trends and the reasons for those trends and fix those issues, whether it's a technology issue or a human error issue or educational issue, et cetera, et cetera. Or maybe just yelling at your EHR vendor. um, there's a lot of fingers that can be pointed, and we are all relying on each other in order to make this as successful as possible. So, depending on how you're connecting to the source systems, and how that data is mapped, and the complexity of your organization, and the how the standardization of your documentation among your providers. Those are all achievements that we're all, I think, striving for, but are difficult for a variety of different reasons. So we kind of take them all case by case and don't make any assumptions, and always try to verify that what we're doing is showing us what we expect.
Great. All right. I've got a question here. There's a lot of acronyms, so here it comes. My ACO is 6 FQHCs, 2 certified EHRs, 1 out of 5. All will report fire to HRSA on the measures QPP needs. Can the ACO report these fire files for ECQMs?
Really good question. So this scenario, I'll answer this hopefully for other people as well that don't have that exact scenario. Um, it's required that the data be in the EHR, but we don't have to get it directly from the EHR. So if you have an enterprise data warehouse, for example, where all your practices are already connected and all that data already exists, we can pull it from there as long as it hasn't been manipulated between the EHR and us. So if you're already aggregating the data, we can pull it from that centralized data repository. We don't have to make those direct connections.
Great.
Hopefully that helps. And so yeah, uh, part of any of these reporting requirements is that you're attesting to certain things, and that would be one of the things that you're attesting to is that that data has not been manipulated between where it where it was documented to where we received it. Um, so yeah, very very good question.
All right. Next question here, and we've still got them coming and coming, and so keep sending them on. If we run out of time, again, someone will reach out and answer your question via email. This was a two-parter, and actually it's because the same person asked a couple questions here, but I'll ask them at the same time here. First of all, are you able to provide a link to the EHR types that you currently work with, which I figured you probably would.
Okay.
And then the second is, are you able to do a direct connection with Epic, and do they allow you in for a pull connection?
So can you ask me the first question again? I'm
Yeah,
sorry.
for sure. Yeah, the two different questions here. The first one is, are you able to provide a link to the EHR types that you
Yeah.
currently work with?
So I kind of alluded earlier to the fact that we have connected to over 200 different EHR systems. So I'm assuming that when they say EHR type, they're talking about have you connected to Allscripts, Athena, and eClinicalWorks, and et
Right.
cetera. I certainly have that list and can provide it based on conversations, but that covers almost everything. So there's not many that we find that we haven't connected to. I'm not saying that they don't, there's certainly more than 200 out there. Um, but even the ones that we're not familiar with, that doesn't necessarily mean that we can't pull data from their EHR. It just means that we haven't yet. And either way, if there's a QRDA1 file that we can push to us or a CCDA file, again, there's a lot of no statement of work is ever 100% like one way. It's almost always hybrids based on, what EHR is it? What are their capabilities? There is to the point of the Epic question, there are some EHRs that we don't have pull capabilities with, and sometimes it's a technical reason, and sometimes it's politics. Like I don't want to give you read-only access to my database. I'll just push it to you. So sometimes that's the best that we can do. And as far as Epic, we have pulled data out of Epic using Care Anywhere, but I believe most of our organizations that utilize Epic are pushing us that data today. So we have flexibility, but that's typically, I think, the way that we're doing it for most of those organizations.
Yeah, very, very good. Goodness, we still have some really great questions rolling in. So unfortunately, we are not going to be able to get to all of those today, and we're actually needing to wrap up here. But I want to assure you that someone will reach out to you to answer your questions. So keep throwing them at us here until we close out. As we close out, and first of all, James, thanks so much. This was a fantastic presentation. You were able to handle a pretty weedy topic in a way that was very engaging, and really appreciate that. As we close out, I'd like to encourage you all to head over to vbcexhibithall.com, and there is a virtual exhibit booth that MRO has there, and you can read up on them and see what they're doing and really educate yourself on what they're doing in the space. And of course, there's ways to reach out to them there, and just a lot of great resources in general in vbcexhibithall.com. In our library where you can educate yourself on a variety of different topics within value-based care. But feel free to browse around but check out that MRO booth. And then finally, If you would like to reach out to James or to the MRO team, feel free to do that. Yeah, there you go. His information is on this final slide, and so you can reach out to him via email or call him. Or if you'd rather reach out to me, I'm happy to facilitate an introduction as well. But wanted to thank you all again so much for spending your afternoon with us. Thank you, James, for the presentation, and we hope to see you on the next one. So until then, have a wonderful rest of your week.
Thanks,
Bye bye.
Garrett.